Hello and welcome to the MIT System Design and Management Program's Systems Thinking webinar series. My name is Lois Slavin and I'm the SDM Communications Director. Our speaker today is Dr. David Hartzband, and he will be presenting on the topic of healthcare IT. Before we start, a couple of housekeeping items. If you have any questions, please enter them directly into the chat section addressed to everyone. There will be a Q&A at the conclusion of Dr. Hartzband's presentation, and the questions will be read aloud. Secondly, the recording and the slides will be made available within about a week, and you will be sent an email with the links to those resources. Third, if you are an early to mid-career professional who is interested in the System Design and Management program at MIT, we will be having a live virtual info session on Tuesday, December 6th. Please go to sdm.mit.edu for further information. And now, I'm going to turn this over to Dr. Hartzband.
Thanks, Lois. And thanks to SDM. I'm always grateful for the opportunity to get to present some of this work. This morning I'm going to be talking about a project I've been doing for about the last year and a half on updating health information technology infrastructure for a primary care organization that serves the state of Texas. PCAs, or primary care associations, are those organizations that were chartered by the Public Health Act to provide guidance and services to federally qualified health centers, what we often call community health centers, or CHCs. The Texas Primary Care Association, which is called TACHC, the Texas Association of Community Health Centers, provides services to about 75 of the 92 community health centers in Texas. And the kinds of services that it provides are things like provision of IT services, consulting and analysis, a health center controlled network that I'll explain a bit more as we get into the seminar, a health information exchange, which allows health centers across Texas to provide information on common patients, an accountable care organization, which is a risk-sharing payment organization that's chartered by Medicare and Medicaid, administrative assistance, assistance with community relations, etc. And all of these services require IT expertise and provision of an IT infrastructure. So let me spend a minute on what the problem was that we were trying to get at. And let me also say that this problem is relatively typical with both primary care associations and with community health centers and with organizations of community health centers. Each one of them has kind of its own set of details, but the general shape of the problem is the same. At TACHC, the IT group was really not meeting either internal or external needs. None of the services that it was providing to its constituents, that is the 75 community health centers that it provided services to, were working very well. None of them were being used by the constituents. They had a huge backlog of requests. They were way behind on bug fixing. The group really did not have standard management practice for software development. The Health Center Controlled Network, or HCCN, and physical networks weren't really working very well. They were right at the edge of the amount of data that they could store given the infrastructure that they were currently using. And more strategically, they had little or no focus on data in the larger sense. I've written quite a lot about this, and there'll be some references in the slides that you'll be able to see once you get the slides, on a concept that I call data as an asset, as well as data awareness. And there was almost no thinking like this at the association. The IT director's plans at the time called mainly for upgrading their databases. They were basically underwater. And in the bigger picture, there were 4 or 5 different groups at TAC. There was almost no communication among those groups, and there was almost no common planning. So I'll get into how this came to be in a minute, but I proposed a project to the management of the association that looked at doing work in 3 areas. The first area was to try and normalize the IT group and to update the infrastructure to facilitate both the IT services that it was trying to provide and the analytics services that it was being asked to provide, but was not at this time providing. The second area was organizational, where I proposed evolving kind of a parallel analytics group with a staff that originally would be drawn from internal people and would come under a CTO, where the association did not have a CTO, but where CTO would manage both the IT infrastructure groups and this new analytics group. And there were other organizational changes that were being proposed, and cultural changes where a focus on data awareness, that is the use of the alignment and use of data and information in accordance with the strategic goals of the organization, and to evolve a more collaborative environment, both internally and with the health centers that were being served. So I had done a project previously with TAC, which was a project where we really emphasized the deployment of an analytic software stack and training in the use of those analytics. And that software had been deployed, and I'll talk about that in a second, but the project had basically been deferred after we got preliminary results. So that work had already been done. But in April of 2015, the executive director of the association contacted me, and we had a long discussion about things that he thought needed to be changed at the association, both within the IT group and culturally in general. It took quite a while to negotiate a contract with the association, but eventually in September of 2015, we did agree on a scope of work and how to proceed. I went to, the association is located in Austin, Texas, and so I spent a week in Austin in October of 2015. And the first day that I was there, I was meeting with the executive director and his staff, and people on his staff started telling him about a number of very major issues, some of which were related to IT, some of which were not, that he hadn't known about before. And apparently just the beginning of this project was the motivation for some of these people to come forward. Some of these issues had been brewing for 6 months or more, and the executive director was, as you might imagine, somewhat concerned that this was the first he was hearing about them. One of them was, in fact, that all of the Microsoft software that they used had come off license about 4 months before, and the licenses had not been renewed. and he had never actually been asked to approve renewing them, and the amount of money to renew the license, even though this is a nonprofit foundation, was so large that nobody wanted to tell him about it. And so Microsoft had apparently decided that primary care associations were not really nonprofits, and they were going to charge the full license fee to use all of the databases they were using, the collaboration software, Microsoft Office, and all of the other things that had been licensed. As I said, this was the first that the executive director had heard about this, and he was quite angry, I would say, would be a word. In the middle of this, the IT director at the time resigned. A lot of fingers were being pointed at him, and he just said, "I don't need this," and he walked out. And he didn't come back. Despite this, the proposal that I had reviewed for several months then with the director was reviewed with his staff, who were mildly positive about it, knowing that something had to get done, except for one group. And the remainder of the IT group was quite opposed, and in specifically the fellow who was the lead programmer, who now essentially was the head of the group, was opposed to any change at all, either in the organization of the IT group or in how it did its work. Despite this, the executive director and his staff decided to go ahead with the project. This was in October of 2015. A little bit of background. You'll get these slides, and you can see a lot of the stuff that I've written about data awareness and data as an asset. Both of those are on my blog, which you could look at before you get the slides at posttechnical.blogspot.com. A little bit about the organization of TAC. There is an executive director. He has a staff of 7 or 8 people. There's a clinical division, which is run by a medical doctor. Most of the staff in the clinical division are registered nurses, although there is one other doctor on staff. There is a community development group with a staff of about 5, an administrative team with a deputy director, and a rather large staff, 2 of which are attorneys. The executive director, incidentally, is also an attorney. There's the IT infrastructure team, which had a director who resigned and a staff of about 7, and some miscellaneous other people for a total staff of between 35 and 40. So in October 2015, the IT group consisted of a director and 4 programmers. But by March of 2016, that should be, the director had resigned, the lead programmer had dug his heels in, and the work process for the group was that individual programmers talked to individual people in the other groups who made requests of them for software tools or analysis. There was no common process for prioritization or assigning this work. An individual decided that they would do the work. There was no overall code management or bug fix system. People kept their own work on their own personal storage, fixed their own bugs. There was no centralized way of telling what had been fixed and what wasn't. And there was no overall development plan either for software or infrastructure. This despite the fact that the group had had a director for about 5 years. So this was not an ideal situation. With respect to infrastructure, it had been built up over time as it was needed. The Health Center Controlled Network, Health Information Exchange, and Accountable Care Organization all used separate databases. There was no interconnection between those databases. They had totally separate code bases, and in fact, all three projects even used different programming languages. That wouldn't necessarily be a problem, but in this case, they were seen as being quite incompatible. The network which the association provided to their constituents, that is the individual health centers, was neither secure nor particularly reliable. As the executive director found out in October of 2015, not all the infrastructure software in use was properly licensed, and designs were quite eclectic and in some cases not easily integrated. By eclectic, I will mean when I did a design review, which was the first time they had actually been looked at, I was quite surprised, even with 25 plus years of software development and design experience, at how a lot of the software had been designed and implemented. Give you a little bit of an example. If you look left to right on this slide, the elements in green are external to TAC, and the elements in blue are internal. If we just look at the health center controlled network, which essentially is providing a data warehouse for the use both of TAC internally to do analysis and the use of the health centers, what would happen is that every night each health center's EHR would download, there'd be an ETL process which would download data from approximately 30 different health centers. Those 30 health centers used 8 different EHRs. And so the ETL process was entirely done through stored procedures in MS SQL Server. Now, a little bit of background on me. 211 years ago, I was Digital Equipment's representative to the ANSI Standards Committee that standardized SQL the first time. And I actually made a proposal not to allow stored procedures in the standard because I felt that they were not transparent enough and that they, if used as extensively as I thought they would be, would mean that debugging such programs would be virtually impossible. Obviously, I lost that battle to IBM and Sun Microsystems at the time, and stored procedures were put in the standard. I still don't believe that using stored procedures to do this kind of work is ideal. And in fact, the ETL process for these 30 EHRs took longer than overnight, each night. And so that was part of the problem. It also was very, very buggy since one person had written all of the stored procedures and basically had just copied and pasted a lot of it. The results of the stored procedures, that is the ETL data, was put into a working database, which actually was an MS Access database. Don't ask me why. And once a day, that was downloaded into a data warehouse that was a standard SQL Server database. This SQL Server database was basically falling over with respect to how much data it had in it, not because SQL Server couldn't manage that amount of data, but because the schema for this database was extraordinarily, I will say, inelegant and inefficient. It had about 600 tables, which was probably about 500 too many. And so the final three blocks there are a user at the PCA who can request analysis from the warehouse, and this is basically just SQL-based analysis. So what were the proposed changes? What I proposed was in part based on what we had done in the previous project, which was called Path to Analytics, and that I've reported on here in the SDM webinar series. I proposed creating a parallel data storage based on open source HDFS. We used the Cloudera distro, populating HDFS from the current data warehouse, and also populating it with financial and operational data from the CHCs, as well as a wide variety of external data. And then the use of analytic tools associated with Hadoop to do analysis, and eventually to be able to write predictive models in Pig or Python, or pick your favorite analytic language. And in parallel, to also use visualization tools for data summarization. I initially recommended Tableau. I still think Tableau is a good tool, although I've been using other tools recently. And the association did license Tableau, although initially the only people licensed to use it were 2 people in the IT group. And then to begin training and hiring for analysts, and to move toward predictive modeling capability. These were just the proposed infrastructure changes. And this is a schematic of what that would have looked like, where you still have the data warehouse, although taking out the MS Access database and redoing the ETL processes so that they were more efficient and effective. And in parallel, reading data from the data warehouse and from external sources into HDFS, using an analytics server, and then being able to do analytic queries as well as report generation as was currently done. So as I've said, as part of a previous project, we actually deployed the Cloudera distro into TACHC, and did preliminary analysis with MapReduce 2 and through massively parallel SQL. Just as an aside, the use of MP-SQL to do this type of analysis, I think, is extraordinarily important, because if you look at many of the organizations that are attempting to move toward this type of analytics, they have a lot more SQL programmers than they have Pig or Python programmers currently. And so this is a process. So we used MP-SQL. We actually also used Python, and we did a bunch of preliminary population health and care planning analysis. We had a lot of interesting results, not just from TACHC, but from the other people here. And we have a paper in review at the Online Journal of Public Health Informatics, which is cited here. And I also have several blog posts on this project. So this had already been done at TACHC. So what then happened? So after the first site visit in October, I had made some very, very detailed proposals about the establishment of code management and development planning systems, that priorities and schedules had to be set in 3 and 6 month software development intervals, that work had to begin on the redesign of the health center controlled network. We focused on the HCCN because it was the thing that the constituents told us they most wanted revised, because they would use it if it was revised. They actually didn't see that they were getting much out of either the health information exchange or the ACO. And then to begin work on the evolution of the infrastructure to actually harden the deployment of Hadoop that had already been done, to take it off the virtual server where it was, and to bring it onto a set of physical servers, and then to begin the organizational changes needed to incorporate an analysis group and to hire the CTO. I'd have to say that the lead programmer basically put his foot down and said, no, I'm doing all the programming, I'm going to hire all the people, I'm going to keep all of the files on my personal computer, I don't want any design or code reviews, and I'm going to do the HCCN revision myself personally. I know what the health centers need, they don't. I have to say on this last point, I have a little bit of empathy for him. When I was one of the lead architects at the Digital Equipment Corporation, we used to be told that we had to go and ask our clients like Boeing and General Motors what they wanted in future software releases, and invariably they would say, fix bug 57A. And I would say, we're fixing bug 57A, but what do you actually want in the next release or in the release after that? And they would say, fix bug 57A. I don't think that software engineers know better than the people using the software what to design and how it should be used, but that was the position taken here. So we went back into kind of discussion mode. And again, he was told that he wasn't going to be CTO and that he was not going to get to write all the programs himself. He did threaten to resign, and subsequently, a month and a half ago, he did resign. But in October of last year, he decided to stay. So what other work did we do as we really started down this path? One of the proposals that I made was that there needed to be many more opportunities for collaboration among the groups in the association. Joint meetings of the IT and clinical teams were initiated. These meetings were very, very successful. And the primary thing that came out of them were two things. One was the actual requests that the clinical team felt they needed, as opposed to what the IT team thought the clinical team needed, and setting priorities for how to meet those requests. We also set up a association-wide wiki to allow intergroup communications. This was looked on quite dubiously initially by most people. Almost no one, everyone at the association used social media, but almost none of them had ever used a wiki or really were familiar with the concepts of it. But it was set up. Some people started to use it, particularly the fellow who was head of community development started using it quite extensively. And after a while, and his people using it and the IT group using it, it started to become much more used. We also started taking the first steps toward breaking out the analytic function. The visualization software was installed, and 3 people who were already doing analysis were given access to it. Meetings were started to develop projects for visualization and priorities. This was pretty significant, as this was the first time any software tool, any significant software tool, was made available outside of the IT staff. Current status, in August of 2016, a CTO IT director was hired. I was part of the hiring process. This person had a background entirely in IT ops management with no background in analytics or any other advanced technology. He came from one of the large Blue Cross Blue Shield organizations where he had been an IT operations manager. My recommendation was to hire him as the IT director and continue looking for a CTO. Having been a CTO at a number of very large and very small companies, I had some idea of what I thought was required. But this candidate refused to take the job unless he got the title and unless the executive director assured him that the search for a CTO would be terminated because he was the CTO. So he was hired under those conditions. His priorities, once he came in, were kind of fixing the network, upgrading the databases, rewriting the ETL process, and redesigning the HCCN UI. These weren't bad priorities. I was just concerned that he really didn't have a larger picture view of things. He wasn't opposed to establishing an analytics function. He just didn't think it needed to happen for 2 or 3 years. The director of community development moved forward with the collaboration and data awareness initiatives, but other than in his group, little or no progress was made until very recently, and I'll talk about that in a minute. And many of you may work in healthcare, so you know that the changes that are coming in 2017 with the MIPS program are the highest priority probably for most HIT groups right now, and that was the case here. Also, the revision of the ACO because the association wanted to provide an alternative payment method for the health centers that it served so that they could do MIPS qualification. The executive director still wants to do the analytics and collaboration aspects, but work has to go on with the current priorities. So the CTO has submitted a plan. It's not a bad plan. It has good short-term focus on process and improving the current infrastructure. It has a good midterm focus on redesigning the HCCN and the ACO so that they're usable and useful to constituents. His view is really 18 plus months for focus on collaboration and probably 24 plus months for forming the analytics group and doing any technology changes to the infrastructure other than improving the current infrastructure. The technology changes that he has proposed are using Microsoft Analytics and SAS rather than Hadoop and a separate analytics stack. The executive director has continued to support my continuing salary plan for 2017. But one of the positive aspects was he started using the wiki a couple of months ago for his own internal communications and collaboration. And that put a lot of pressure on his staff to use it. And so the wiki is starting to get a lot more use and a lot more intergroup communication is taking place. I'm doing a series of presentations, remote and on-site for TAC, to present a series of cases and examples on the use of analytics so they continue to get kind of oriented with respect to why this is important. This is just a project timeline that I'm not going to go into in any great detail, but it just shows that discussions began in March of 2015 and we're now at close to the end of 2016, and we're we're still trying to get some of the initial core parts of the plan that I proposed deployed and used. So some of the things that I relearned here, all of which I knew, but each time you do one of these projects, you kind of get hit upside the head again with them, and I'm sure most of you know them too. This is a tautology. Organizational and cultural change is hard. We all know this. We just tend to forget how hard it is and forget all of the little and big things that mitigate against change in organizations. Technological change is actually much easier. In fact, the problem is that technological change these days often requires organizational and cultural change, as it did in this case, as a precursor. Once those organizational and cultural changes are made, the technological change is actually quite simple. Consistent executive sponsorship is essential. The executive director in this case always supported the project, but he always supported it at different levels of enthusiasm, and his staff was very fine-tuned to understand his level of enthusiasm and basically responded at his level of enthusiasm. When he was enthusiastic, they were. When he wasn't as enthusiastic, they weren't. Again, we know that champions have to emerge internally in order for these changes to take place. That has started to happen with the director of community development starting to play a bigger role in the organization, and now again with the executive director using the wiki and trying to set an example for collaboration. The new CTO, or relatively new CTO at this point, is also setting an example. We know that these kinds of changes can't be mandated from the outside, and as I was told continually by this group, especially by, quote, experts from MIT, unquote, much to my chagrin, they insisted on calling this the MIT project. I tried to convince them that it wasn't an MIT project, it was their project. But so long as efforts like this are seen as an external project, they have a particular character and really will need to struggle. And finally, it is the people, stupid. The people make the difference in how change is perceived and how it's pursued. And understanding not just the organizational structure, but the organizational fabric, how the individual managers and employees fit into that fabric, what the informal communication and influence structures are, is every bit important, if not more important, as understanding what the formal communication and influence structures are. Just because the executive director says, make this so, it doesn't mean that everyone feels like it should happen or will work on it. And so it really is the people. That's what I've prepared. I said it'd be about 40 minutes. I think we're right about there. And I'm perfectly happy to take questions for a while if there are questions.
Thank you, David. We have one question so far from Collier, who asks, your executive director seems intent upon using you as a tool to implement change within his organization. How do you personally navigate the conversations with the technical folks you work with without stating that the executive director said so and alienating the team?
That's a great question, actually. I think there is some pretty thin ice there. And one of the advantages I have is I've been doing software development and relatively well known for doing software development and consulting on software development for about 800 years. And so I can step back and say, in my experience, and then give examples of where things worked and where they didn't work, particularly when things were as black and white as this, where there was little or no collaboration among groups, where no software management practices were being used in IT. And so it's, it becomes much easier to use examples rather than, you don't ever want to be in a position where, as an outside consultant, you have to say, do this because I said so, or do this because your boss said so, or your boss's boss said so. That's immediately guaranteed, number one, to blow your credibility, and number two, to get people to dig their heels in opposition. And so what I found is, by using experience, by being able to go back and explain examples and explain cases where I've seen similar kinds of things and I've seen what works and what doesn't, excuse me, I can maintain both the technical and the consulting credibility that I come in with, and interact directly to be able to hopefully improve things. Now, I'll just say in this case, because the IT group was so poorly organized, and because the lead programmer was so obstinate with respect to how he wanted things to happen, it was a little bit more difficult. But I was able, outside of the IT group, to convince people that these changes really needed to be made, and the changes in the IT group even really needed to be made. And so that is what allowed a lot of this to go forward.
Thank you. Folks, if you have any questions, please type them directly into the chat section addressed to everyone. We welcome your questions. While we are waiting for people to chime in, I just would like to let folks know that there will be a live virtual info session on the MIT SDM Master's Program that will be held on December 6th. That's a Tuesday. And if you're interested, you can find details at sdm.mit.edu. So we have several new questions here. One from Amar Gupta. Did you have to deal with companies like Epic and Cerner to achieve your goals? Also, are you using the integrated information to support telemedicine?
To support?
Telemedicine?
Telemedicine. Okay, a couple of different things there. As I said, there were 8 different EHRs that were represented by the constituents. Epic was one of them. None of the Cerner is typically not used by community health centers. I know of some that do, but only because they're associated with hospitals that use it. The EHRs that were primarily involved were NextGen, eClinicalWorks, several Greenway EHRs, and Epic, and then there were 3 or 4 others that were either singletons or used by 3 or fewer of the health centers. The primary EHRs that were in use, thank you. The primary EHRs that were in use were ECW and NextGen. With respect to telemedicine, The association is currently not supporting telemedicine for its constituents, although there are a number of groups of health centers in Texas that have created their own telemedicine networks, and the association is looking at supporting those networks. One of the issues with telemedicine is billing for telemedicine, and there's still some ambiguity with community health centers, which bill differently than hospitals or other types of medical practices, as to what can and what can't be billed with respect to telemedicine. So I hope that answers both aspects of the question.
Okay, from Joseph DeSanto. What about the role of software engineering quality and process organizations? For example, SEI.
Mm-hmm.
Was this an SEI level 1, 0, I think that says, software development group?
Okay, so this is one of my, I won't say hot buttons, but I actually worked with the group at Penn State when SEI got set up originally. I'm a big fan of process in software development, and that's one of the reasons why I proposed instituting a good deal of process. I'm not a big fan of certifiable process in software development. And so we did not follow SEI. This was a choice on my part. It might be the wrong choice, but I've been very, very successful over the years with a set of processes which I believe are every bit as stringent as SEI's, but which emphasize slightly different things. That's really all I'm going to say about SEI. In terms of the kinds of process that we did put in place, as I said, I very strongly believe that design, planning, code management, and bug fix processes have to be standardized, have to be supported by standard software, can't be supported by I have it in my head or it's on my disk on my machine. And we did put in place a set of processes supported by Atlassian software that I believe will be much more productive in terms of how software is designed and developed than the kind of ad hoc idiosyncratic development that was used previously.
Thank you. Next from Rachel Pohl, who says, many in accountable care system design are focused on the opportunity to integrate, hold on, just lost my little place, to integrate health-related social needs, which are the social determinants of health. In particular, housing and food security. I see in the TAHC website that some of its members are public housing and homeless serving health centers. Would you comment further about the experience in working with clinical, community health workers and diverse workforce and community leaders in creating the infrastructure that will serve the goals of improved outcomes and cost savings over the next 10 to 15 years?
Yes. Well, let me talk specifically about social determinants. There have been, and you're absolutely right. We really are kidding ourselves thinking that we can improve healthcare unless we also are dealing with social determinants. The two that you mentioned are important, but the other determinants, such as employment, are also important. So there has been a very large movement in the community health center community, which has been led by a group called APCHO, which is, let me see if I can get this right, the Association of Asian and Pacific Islander Community Health Centers, led by a community health center in Honolulu. And they have actually proposed extensions to EHRs to capture social determinant data. There are a number of very large health centers and health center controlled networks that are using those extensions with systems like Epic and NextGen to capture data on food habits, food security, employment, addiction, homelessness, the whole range of social determinants that have been specified. The federal government has not so far indicated that it will make any use of this data, but health centers are making use of this data, particularly in interventions in care planning and also in larger population health interventions. So this is a very, very important movement that I think we're right at the beginning of. And one of the things that over the next 2, 3, 4 years, I think will be important in improving outcomes, improving care planning, improving outcomes, and improving how we use this data overall. In terms of other things, it's not just ACOs that are using this data. Like I said, there are many large health centers and other types of healthcare organizations that are beginning to try to collect and use this data. Right here in Boston, there is a community health center that actually runs a food bank and a farmer's market for its constituents. So knowing about this data allows for different types of interventions than we might have thought were necessary without having this data. In terms of what other kinds of things are important as we move forward, I think the whole move toward the use of population health analysis is going to be critically important on a larger scale. This isn't going to, well, it may in fact help individual care planning once we have populations characterized at a better level. But the ability to do larger types of interventions and for the government and for other kinds of organizations to do larger types of interventions are, will be greatly facilitated as we do more and more population health analysis. I think the whole area of analytics is one that is going to be extraordinarily important, which is why I started the Path to Analytics project and why I agreed to do this project with TAC. If we think about MACRA and MIPS and the whole idea of risk-shared payment models and operational optimization, even if we're not looking at individual health outcomes, the use of analytics is absolutely essential. We can't get around it. And these are analytics that are quite different than what we've been doing simply with business intelligence reporting on this is how many diabetics we have in our population, or this is how many heart attacks people had in our population last year. So I think there are a number of things that we're looking at. I'm sitting here in E40 on the MIT campus, and I'm very aware that IBM Watson Health moved in 2 blocks from here and is putting about 700 people in their building down on Binney Street over the next 12 months, talking with them about the kinds of things they're looking at. Obviously, Watson does a different thing than this. Watson is a learning system. But being able to do predictive learning, being able to use predictive and cognitive systems for care planning and for healthcare administrative optimization, I think is going to be huge in the next 3 to 5 years, probably not in a time frame lower than that, except if you're Kaiser or Geisinger or some of the more advanced healthcare organizations in the country. So I think let me end there, and please, you have my email there. Please get a hold of me if you want more of my thinking on this, or I've written a lot about these topics on my blog, so please look at my blog as well.
Thank you. Just to let folks know, we have about 3 or 4 more questions at this point in the queue. If David's amenable, we'll go over, we'll go past 1. And for those of you who aren't able to stay, we'll keep the recording going, and you can check the link when it's sent to you and hear what you might have missed. From Katiuska, have you had the experience of implementing a similar cultural/IT change whose results were closer to the original plan?
Not in healthcare. In discrete manufacturing, in both auto and aerospace, I've done similar projects at General Motors and Boeing. I don't think, there's an old adage that in the military that no plan ever survives first contact with the enemy. And I think there must be a version of that that's true in organizational change as well. I've never had a plan, whether I did it or whether it was done in collaboration with colleagues, or whether I've worked with groups, for instance, at Wayne State University, at General Motors, who had very detailed cultural change plans. None of those plans ever survived the initial deployment in the organizations that were the focus of the plan. And so I guess I would have to say I would be surprised if I was speaking with someone and they said, we did this plan and then we implemented it exactly the way it was written. And then I would want a lot of detail. I have done actually larger changes. At General Motors, we did this with a team of cultural anthropologists from Wayne State University, the head of which was Marietta Baba. Dr. Baba is now provost at Michigan State, but was head of the anthropology department there for a long time. And she's written extensively on industrial anthropology and making changes in industrial organizations. So I would point you at her work. She's much more eloquent about this than I am. It's B-A-B-A, M. Baba from Michigan State. And you'll find a whole wealth of things, including stuff about the C4 program at General Motors.
Okay, from Susan Anderson. Were you successful in building a clear understanding of the problems that a cleaner IT infrastructure would protect against? For example, with data security or retrievability?
I guess I would come back and once again come back to the adage that it's the people stupid, me being stupid. it's difficult to build a clear understanding when the people that you're working with refuse to acknowledge that there's a problem. And because both the IT director, when he was still in place, and the lead programmer felt that what they were doing was more than perfectly adequate, they were not oriented toward admitting that there might be a problem with data security, data quality, data hygiene, or anything else with respect to what they were doing. I was more successful in building that understanding, although, again, I think everyone brings their own version of this understanding to the table. You build a very different understanding of the need for change in IT infrastructure with an experienced IT manager than you do with an experienced community relations manager. But I do think that I was more successful at convincing some of the other staff people, particularly the chief medical officer and the head of the community development group, that these changes were necessary. And again, I think that's because of who they were and the fact that they were much more amenable to thinking about what might need to be changed and what was difficult with the current way things were being done.
Okay, we have two last questions. One from Connie Bowe, who says, project leaders tend to rely on early adopters to promote their goals, but in my experience, they can increase the resistance to new ideas or ways of working when those with legitimate concerns don't feel heard. How do you expand discussions of the diffusion of innovation spectrum groups to build a broader base for change? Or as a consultant, do you leave that to be managed internally?
I'm not sure that's always able to be managed internally, and here it wasn't. So I actually very deliberately picked a number of people out in the organizations to work with on this. Excuse me, too much talking. One of them was an RN in the clinical group who was going to be one of the analysts and who really relished this role and took it on and became a champion. Another one was someone who worked for the community development manager. So I do think you have to be proactive with this. Consultant, I don't believe, although I've seen lots of consultants and lots of consultants that get paid much more than I do, walk away from issues like this and say, well, if the organization chooses not to do this, then that's their issue. But I believe that it is incumbent on the consultant to take up these kinds of issues.
Okay, and our last question is from Derek. It is interesting the infrastructure is being built prior to and not in conjunction with the analysis team, including staff, expertise, capabilities, and project management. Do you anticipate substantial rework on what is currently being developed, or are there best practices that are independent of downstream use and specific project management processes? It would seem you would have to know how the data will be used to develop an optimal solution.
Well, I think that's a more nuanced question. I think part of the answer is that we have a lot of experience in healthcare with how analytics is currently being used and what's been successful. We even have a fair amount of experience with community health centers, just not with these community health centers. So in part, the decisions on what infrastructure to put in place were made in conjunction with that information base. I do think that there will be some rework and redevelopment and redesign that will need to be done. Again, depending on who steps into those roles and who manages those roles. We also did collect some amount of data from the Texas community health centers with respect to what kind of analysis they wanted to see done. So we had that information as well. And I had also done the previous study, the Path to Analytics study, with a variety of health centers and had the information from that, had the experience and information from that study as well. But I would never say that something that I or any other consultant put in place before the fact was the last word in how something was going to be done. So I think it's, yes, we did have a good deal of information when we decided on what the infrastructure should start out to be. And yes, I do think there will be some redesign as people start using it and we see what needs to get accomplished and how it works.
Dr. Hartzband, thank you for a wonderful presentation. As always, you presented important information in a very actionable way. For those of you who joined us later, after the beginning of the presentation, there will be links to Dr. Hartzband's presentation slides and to the recording, as well as Dr. Hartzband's previous presentations in the series. This presentation was the last one for the fall semester. We will be resuming in the spring semester in February, and everyone that has registered or is on our email list will get notification. Thank you very much for your interest in this series and in this particular presentation. We wish you happy holidays and hope to see you in February.